So, but the exact definition is a macrophage-induced inflammatory response that results in bone loss and implant loosening in absence of infection. So what is the pathophysiology? Particulate debris formation, macrophage-activated osteolysis, prosthesis micromotion, and particulate debris dissemination. So aseptic loosening can also occur due to disruption of the cement implant or the cement bone interface. Implant cement interface is the most common weak link compared to bone cement interface. So this is a 2025 JOA paper. It says that tibial aseptic loosening was associated with significantly thinner cement interfaces when compared between two implant types. A 2020 paper, it says that there is difference in adhesion properties between cements. And this is an important point, use of low viscosity cement on non-coated surfaces in the early liquid phase of cement curing was found to produce the best chance of adequate adhesions. Presently, what we are all using are high viscosity cements, and this study shows that low viscosity cement is better. So, orthopedic community should consider not only implant, cement and curing time individually, but the overall integrity confirmed from the combination of all these three variables. Aseptic loosening is more common in tibial component than in the femoral component. Tibial loosening incidence is about 1.63% as compared to 0.58% for femoral loosening. Diabetics are 8 times more likely to experience aseptic loosening and twofold increase in those patients with BMI greater than 35. So what are the sources of wear debris, which we all know? Articular and non-articular, which is backside wear of the polyethylene, the tibial post, the polyethylene patellar component, metal debris from failed implants, and the cement debris. Amount of wear generated, patient factors is age, weight, and activity level. And surgical factors are malalignment, malrotation, and poor ligament balance. So this is the wear, the poly wear, and the tibial, you can see the wear on the tibial base plate, which leads to backside wear on the poly. So now the radiation dose, usually we don't see the radiation dose on the poly which we use. So wear reduction, as the radiation dose increases, the wear rate of polyethylene decreases. So 50 kilogray is 5 megahertz, approximately 54 reduction in wear, and 10 megahertz is 95% reduction in wear rate. Anything above 10 megahertz will typically level of wear resistance. The Attune poly which we use is on a radiation dose of about 8 megahertz. So again, the sterilization techniques which we had discussed, gamma irradiation in air is historical. Now it is not used. Gamma irradiation in inert gas or vacuum, that is one type of technique, and the second is gas plasma or ethylene oxide. The two implants which we use presently, Smith & Nephew uses the sterile EO technique, ethylene oxide, and the Attune users, we would have seen the poly coming in a vacuum pack. So this is gamma irradiated in vacuum. So what are the symptoms now clinically? Increased startup pain and pain on weight bearing. May have minimal pain with range of motion. The aggravating factors are weight bearing, often related to activity, and in late disease there would be instability. Tenderness localized to the site of the loose components, and AP and ML instability. Now importantly, investigations, how do you diagnose it? The X-ray is the basic investigation. Tibial osteolysis is readily available. Femoral osteolysis may be difficult because of the component, and the location is almost always posterior. Lateral oblique views would be helpful. So fluoroscopy guided X-rays, the first tibial X-ray, you cannot see the loser zone, the osteolysis, but with the fluoroscopy guided, you can see the osteolytic line. In the femur, there is a lot of osteolysis just above the femoral component, and the third one is posterior osteolysis. So this is the 25-year-old operated. You can see the medial subsidence as well as lateral loosening. So X-rays, there is a radiolucent area around the implant or cement with sclerotic border, periprosthetic radiolucency greater than 1 millimeter, change in the position of implant, subsidence greater than 2 millimeters, valgus varus subsidence, progressive widening of the cement bone and bone prosthesis interface, cement cracking or fragmentation. If you see all this on X-rays, then you have to have it in mind that there can be starting of aseptic loosening. CT scan also can help in preoperative planning, CRP, and finally aspiration of the joint to rule out infection. Bone scan also is a good method, but it cannot reliably differentiate between aseptic loosening, infection, and bone remodeling. Increased uptake can persist 1 to 2 years after surgery, even in normal knees. So we can be put in doubt whenever we go for a bone scan that whether it is infection or osteolysis, aseptic loosening. So normal bone scan, loosening, infection, unlikely, but a positive bone scan, you will require more blood tests, joint aspiration, and advanced imaging. SPECT-CT shows high sensitivity up to 94% and specificity up to 86 to 94%. In Ahmedabad, it is available in GIC, and it is an effective tool to diagnose aseptic loosening. So X-ray first line, bone scan is a screening tool, SPECT-CT is good nuclear option, MRI limited due to metal artifact, and joint aspiration gold standard for infection exclusion. So the management is single stage revision once you have ruled out infection, removal of implants, planning based on the bone loss, and reimplantation. So these are the methods. You can use an osteotome, stacked osteotomes, or a punch to remove the tibial component. Giggly saw also is used, and this is how we remove the implants after using the giggly saw. The tibial implants with the osteotome. The importance here is there is no cement on the back side of the tibial base plate. Like the studies said, that that is the weakest interface, the implant cement interface. And so the femoral implant, the cement is almost on the implant, good adhesion, while in case of tibia, almost all with the bone, not with the implant. So the classification of bone loss is the AORI classification, Anderson Orthopaedic Research Institute. First is full metaphyseal bone, second is damaged metaphysis, and third is deficient metaphysis. This is type 1 femur, type 2, one or both the condyles involved, and third is the collateral ligaments gone, maybe a supracondylar fracture. In tibia, metaphyseals intact, one or two condyle gone, but still the ligaments are intact. 2A is above the fibula tip, while type 2B is below the fibula tip, and third is below the level of patella tendon insertion. So type 1 routine revision, type 2 bone graft augments, and type 3 custom implants. So revision replacement, which will be taken in the next topic. Take home message is aseptic loosening accounts for 15 to 30%. It is typically several years after surgery, and on an average 7 years after implantation you can see some signs. Diabetes and high BMI are risk factors. Tibial component is more prone. X-ray is the diagnostic tool. Aspiration to rule out infection, single stage revision. Thinner cement mantle at bone implant interface is associated with higher rates. Maintaining uniform, adequately thick, well penetrated cement without defect is important to prevent loosening. And orthopedic surgeons should consider not only implant cement and curing time, but a combination of all these three variables. Thank you.